Welcome back to the Deep Dive. Today, we're tackling something really fundamental, the physiology and, importantly, the pharmacology of adrenal hormones. We want to achieve, true mastery here.
Absolutely. These hormones, they're literally essential for life. They control so much, your stress response, metabolism, salt balance, everything.
And people often just think stress hormones, but it's way, way deeper than that, isn't it?
Oh, definitely. We're talking about these powerful steroids from the adrenal cortex, glucocorticoids, mineralocorticoids. We need to get into the nitty-gritty, the exact mechanisms, how we use them therapeutically, and crucially, the safety aspects.
Right. The mission today isn't just a quick overview. It's about getting that professional level understanding. We're pulling together insights from, core pharmacology text to really unpack the natural hormones and the drugs derived from them.
Okay, so let's start with the source itself, the adrenal cortex. Structurally, it's quite distinct.
Yeah, the gland itself is like two organs fused together, right?
Yeah.
Cortex outside and medulla inside. We're focused on the cortex today.
Precisely. And the cortex makes steroid hormones, all starting from cholesterol. Its structure is key. It's layered into 3 zones.
Okay, let's map that out. Outside in, that seems logical since structure dictates function here.
Perfect. So the outermost layer is the zona glomerulosa. Think glomeruli, little balls. This zone is all about mineralocorticoids.
Aldosterone territory.
Exactly. Aldosterone is the main player here. Its job is regulating salt, water, and very importantly, potassium balance. Basically, fluid and electrolyte homeostasis.
So, critical for blood volume, blood pressure, keeping the whole system stable.
That's it. Now, moving inwards, we hit the thickest layer, the middle one, the zona fasciculata. Fascicles means cords or bundles of cells.
And this is cortisol central.
You got it. This zone churns out glucocorticoids, with cortisol being the principal one in humans. Think metabolism management, stress response initiation. That's cortisol's domain.
Okay, outer glomerulosa for aldosterone, middle fasciculata for cortisol. What's the innermost layer next to the medulla?
That's the zona reticularis. It's more like a network reticular. This layer primarily makes the adrenal androgens.
Okay, 3 zones, 3 main product types. But how are they controlled? Especially the inner 2.
That's where the HPA axis comes in, the hypothalamic pituitary adrenal axis. It's the master control system.
The body's big feedback loop. Let's trace that path.
Okay, it starts upstairs in the brain. The hypothalamus picks up signals. Stress is a big one, but also internal cues. It responds by releasing CRH, corticotropin-releasing hormone.
CRH then travels where? Just locally.
Through a special portal blood system directly to the anterior lobe of the pituitary gland. So it's a very targeted message.
The pituitary acts as the middle manager then, relaying the command.
Exactly. CRH stimulates the pituitary to release ACTH, adrenocorticotropic hormone. You might just hear it called corticotropin.
And ACTH is the hormone that travels through the bloodstream to the adrenal glands themselves.
Right. ACTH docks onto receptors on the adrenal cortex cells, specifically driving hormone production in those 2 inner zones, the fasciculata and reticularis. It has a bit of an effect on the glomerulosa too, but less so.
So ACTH is the gas pedal for cortisol and adrenal androgens. But there's a brake system too, right? The negative feedback.
Yes, and it's incredibly elegant. When cortisol levels rise in the blood, the cortisol itself signals back to the brain.
How does it do that?
It acts as a powerful inhibitor. It tells the pituitary to make less ACTH, and it tells the hypothalamus to make less CRH.
So it shuts off its own production signal, keeps things balanced.
Precisely. It maintains homeostasis unless, there's a major ongoing stressor that keeps pushing the hypothalamus to send out CRH. Understanding this feedback is absolutely critical because when we give therapeutic steroids, we're essentially hijacking and suppressing this natural axis.
Okay, that sets the stage nicely. Let's move from the big picture of the HPA axis down to the cellular level. How do these corticosteroids actually do their work inside a cell?
Well, first, remember, we have 2 main types of activity. Metabolic, glucocorticoid, and electrolyte regulating, mineralocorticoid. They're structurally related, but their effects differ significantly.
But the way they trigger those effects, that mechanism is shared, isn't it?
It is. And it's powerful because it targets the cell's fundamental operating system, the DNA.
Right, because they're steroids, built from cholesterol.
Yeah.
They're fatty, lipid-soluble.
Exactly. So they don't need help getting into the cell. They just diffuse straight across the cell membrane's lipid bilayer. Easy peasy.
Once inside the cytoplasm, what do they find?
They find their specific target, an intracellular receptor waiting in the cytoplasm. These receptors aren't just floating free. They're usually bound up with stabilizing proteins, like heat shock proteins, which keep them inactive.
So the hormone is like a key that unlocks the receptor from these chaperones.
That's a great analogy. The hormone binds, the receptor changes shape, and the stabilizing proteins fall off. Now, where these receptors are found is key to understanding the different effects.
Okay, tell us about the distribution. Are they everywhere?
Glucocorticoid receptors, or GRs, are found in almost every tissue in the body. Brain, liver, muscle, fat, immune cells, you name it. That explains why cortisol and therapeutic glucocorticoids have such widespread systemic effects.
And the mineralocorticoid receptors, the mystereses, are they as widespread?
No, much more restricted. Metabolism are predominantly found in organs involved in excretion, the kidney tubules, the colon, salivary glands, sweat glands, places where salt and water balance is actively managed.
But you mentioned the brain has both.
Yes, that's an important point. Both GRs and MSRs are found in the brain, which suggests they play roles in things like mood, stress perception, and cognition, beyond just metabolism or salt balance.
Okay, so the hormone binds the receptor in the cytoplasm. What's the next step? How does it get its message to the nucleus?
The activated hormone receptor complex often pairs up with another identical complex. It forms a dimer.
Two complexes join together.
Right. Then, this dimer complex attracts other proteins called co-activators or core pressors, we'll get to those, and the whole package then moves or translocates into the cell nucleus.
Into the control room. Now what?
Inside the nucleus, it searches the DNA for specific docking sites. These are called glucocorticoid response elements, or GREs. They're specific sequences of DNA usually located near the start of a gene that the hormone is going to regulate.
So it binds directly to the DNA at these GREs and acts like a switch.
More like a dimmer switch or a volume control. By binding to the GRE, the hormone receptor complex acts as a transcription factor. It directly controls whether a specific gene is read or not and how strongly.
Okay, explain the coactivator core pressor part. How does that fine-tune the response?
If the complex recruits coactivator proteins, it helps unwind the DNA in that region, making it easier for the cell's machinery to read the gene. This turns the gene on or increases its activity. Think about making more enzymes for glucose production in the liver that's turning genes on. And
In core pressors.
if it recruits core pressor proteins, it does the opposite. It makes the DNA pack tighter, harder to read. This turns the gene O off F or dials down its activity. A classic example is turning O off then genes that produce inflammatory signals in immune cells.
This is fascinating because it's acting right at the genetic level, but it sounds like it wouldn't be instantaneous.
Exactly. That's a huge implication because this whole process involves reading genes, making new messenger RNA, and then synthesizing new proteins. It takes time.
Not much time.
We're talking hours, sometimes even days, for the full biological effects to become apparent. This is very different from, say, adrenaline, which acts on surface receptors and gives an immediate response. Corticosteroids have a lag time.
Which is critical to remember when using them clinically, right? You don't get instant anti-inflammatory relief sometimes.
Precisely. You need to anticipate that delay, especially in acute situations.
All right, let's zoom in on cortisol itself. You mentioned its rhythm, the diurnal cycle.
Yes, cortisol follows a distinct circadian rhythm. Levels peak typically in the early morning, around waking time. Then they fall throughout the day with maybe a smaller secondary bump in the late afternoon or early evening.
But stress throws that schedule out the window.
Completely. Any significant physical or psychological stress, injury, infection, fear, surgery triggers a surge in CRH and ACTH, overriding the normal rhythm and pushing cortisol secretion way up.
Okay, let's break down its main jobs. Function 1. Intermediary metabolism. Sounds like energy management.
It's fundamentally about ensuring the body has enough energy, especially glucose. Cortisol is strongly catabolic in many tissues, meaning it breaks things down.
Where does it do that?
In the liver, it powerfully stimulates gluconeogenesis, the creation of new glucose from non-carbohydrate sources like amino acids. It does this by boosting the production of the key enzymes needed for that process.
But where do the building blocks, the amino acids, come from?
From muscle. Cortisol promotes muscle protein breakdown, releasing amino acids into the bloodstream. It also stimulates lipolysis fat breakdown in adipose tissue, releasing fatty acids.
So it frees up amino acids from muscle and energy from fat to fuel glucose production in the liver.
Exactly. Providing fuel for the brain and other vital tissues. This constant push is why long-term high cortisol levels can lead to muscle wasting and changes in fat distribution.
Function 2 seems like a direct consequence. resistance to stress.
Absolutely. When you face a major stressor, think of severe infection, trauma, major blood loss, the body needs a huge amount of energy fast. Cortisol's ability to rapidly raise blood glucose levels is vital for survival in those moments.
Fueling the fight-or-flight response, essentially.
And sustaining the body through the crisis, which
Mhm.
leads to a critical clinical point. If someone has adrenal insufficiency, they can't mount this response.
Meaning stress can be fatal.
Yes. Stress or even just fasting can trigger a life-threatening crisis with severe hypoglycemia and circulatory collapse if cortisol levels can't rise appropriately.
Okay, function 3, it's interesting. Altering blood cell levels. It doesn't just boost or suppress everything, does it?
No, it's quite specific. Cortisol causes a significant decrease in the number of circulating eosinophils, basophils, monocytes, and lymphocytes.
Where do they go?
It pushes them out of the bloodstream and into lymphoid tissues, lymph nodes, spleen, bone marrow. It sequesters them.
But it increases other cells.
Yes. It causes an increase in circulating red blood cells, erythrocytes, platelets, and importantly, neutrophils, the main type of bacteria-fighting white blood cell.
So someone on high-dose steroids might have a high white blood cell count, but it's mainly neutrophils, and it might not mean infection.
Exactly. It's a drug effect, a redistribution, not necessarily inflammation. You have to interpret the white count carefully in patients on steroids.
Now, function 4, the big one from Addison. Potent anti-inflammatory and immunosuppressive actions.
This is why we use these drugs so much. They hit inflammation and immunity from multiple angles.
Right.
We already mentioned they decrease circulating lymphocytes and monocytes.
But they also dampen the activity of the immune cells that remain.
Yes, they inhibit the ability of leukocytes and macrophages to respond to signals mitogens. They basically tell the immune system to stand down. They also drastically cut the production and release of pro-inflammatory cytokines.
The chemical messengers that drive inflammation, like interleukins and TNF.
Exactly. They shut down that signaling cascade.
Well,
But the key mechanism, the one that really sets them apart, is their effect on arachidonic acid.
phospholipase A2 inhibition. Let's unpack that.
Okay, so inflammation involves chemicals like prostaglandins and leukotrienes. They're made from arachidonic acid, which is stored in cell membranes. The enzyme phospholipase A2, PLA2, is what releases that arachidonic acid, making it available.
And glucocorticoids block PL2.
They induce the synthesis of proteins called lipocortins, which then inhibit PLO2. By blocking this initial step, they prevent the release of arachidonic acid.
So no arachidonic acid means no raw material to make either prostaglandins or leukotrienes.
Precisely. This is why they are so much more powerful than NSAIDs like ibuprofen. NSAIDs only block the KOX enzymes, which make prostaglandins. Glucocorticoids block upstream, stopping production of both pathways. It's a much broader anti-inflammatory effect.
Plus, they stabilize certain immune cells.
Right. They stabilize the membranes of mast cells and basophils, making it harder for them to release histamine and other preformed inflammatory mediators when triggered.
Okay, powerful stuff. And finally, function 5. Effects on other systems.
Well, we talked about the HPA feedback. High cortisol also suppresses the pituitary's release of TSH, thyroid-stimulating hormone, which can affect thyroid function tests.
And the kidneys.
Cortisol is actually necessary for normal kidney function. Adequate levels are required to maintain the glomerular filtration rate, or GFR. Without enough cortisol, GFR can fall.
Okay, that covers cortisol pretty thoroughly. Yeah. Let's switch gears to the other main player from the cortex, aldosterone, the primary mineralocorticoid.
Right. If cortisol is about energy and stress, aldosterone is purely about fluid volume and electrolytes, specifically sodium and potassium.
And it acts mainly on those mineralocorticoid receptors, the MRs, in the kidney.
Primarily in the distal tubules and collecting ducts of the kidney nephron, that's its main site of action.
So what does activating those MRs actually do in the kidney cells?
It tells the cells to reabsorb more sodium. It increases the number and activity of sodium channels, called ENA, on the surface facing the urine, and the sodium-potassium pumps on the other side of the cell.
So more sodium pulled back into the body from the filtrate.
Exactly. And water passively follows the sodium, so you reabsorb both salt and water.
Which increases blood volume.
Yep.
And potentially blood pressure if it's excessive.
Correct. At the same time it's saving sodium, aldosterone promotes the secretion of potassium and hydrogen ions, H+, into the urine. So you lose potassium and acid.
A key mechanism for getting rid of excess potassium.
And for helping regulate blood pH. This action isn't just in the kidney, though.
Where else does it work?
It also enhances sodium reabsorption in the GI tract and in sweat and salivary glands. Basically, anywhere the body might lose salt, aldosterone tries to conserve it.
What happens if there's too much aldosterone? Hyperaldosteronism.
You see the direct consequences of its actions. You retain too much sodium and water, leading to increased blood volume and hypertension. You lose too much potassium, causing hypokalemia, which can lead to muscle weakness, even paralysis, and dangerous heart rhythms.
And losing too much acid.
Leads to metabolic alkalosis, where the blood becomes too alkaline.
And if this is due to, say, an adrenal tumor producing aldosterone, how do you treat it pharmacologically?
The main drug used is spironolactone, which directly blocks the mineralocorticoid receptor. We'll talk more about it later as an inhibitor.
Okay, great. We've covered the natural hormones. Now let's get into the therapeutic toolbox, the synthetic corticosteroids. These aren't just copies of cortisol, are they?
No, they're specifically engineered. Chemists have modified the basic steroid structure to tweak the properties, increase the anti-inflammatory glucocorticoid potency, decrease the salt-retaining mineralocorticoid activity, and change how long they last in the body. There are many different options.
Let's start with the most essential use, replacement therapy for deficiency states.
Right. When the adrenal glands fail, like in Addison's disease, that's primary adrenocortical insufficiency, often autoimmune, the person can't make their own cortisol or aldosterone.
And this is life-threatening, especially under stress.
Absolutely fatal if untreated. The cornerstone of treatment is replacing the missing glucocorticoid with hydrocortisone, which is identical to natural cortisol.
And the dosing aims to mimic the natural rhythm.
Yes, typically giving about 2/3 of the daily dose in the morning and the remaining 1/3 in the afternoon or evening. This tries to replicate that diurnal pattern.
Since Addison's affects the whole cortex, do they need mineralocorticoid replacement too?
Usually yes, because aldosterone production is also deficient. For that, we use a synthetic mineralocorticoid called fludrocortisone. It's very potent at salt retention.
What if the problem isn't the adrenal gland itself, but higher up in the pituitary or hypothalamus? Secondary or tertiary insufficiency.
In those cases, the pituitary isn't making enough ACTH, secondary, or the hypothalamus isn't making enough CRH, tertiary. Because ACTH is the main driver for cortisol, you definitely need hydrocortisone replacement.
But maybe not fludrocortisone.
Often not, because aldosterone secretion is primarily controlled by the renin-angiotensin system and potassium levels, not ACTH. So the zona glomerulosa might still be functioning relatively normally. Hydrocortisone alone is often sufficient.
Then there's congenital adrenal hyperplasia, CAH. That's a really interesting use of feedback control.
It is. CAH is caused by a genetic defect in one of the enzymes needed to make cortisol. So the adrenal gland can't produce cortisol efficiently.
No cortisol means no negative feedback to the pituitary.
Exactly. So the pituitary keeps pumping out huge amounts of ACTH, trying to get the adrenal gland to respond. The gland gets hyperstimulated, it gets larger hyperplasia.
But it still can't make cortisol properly, so what happens to all the precursor molecules?
They get shunted down alternative pathways, particularly the one that produces adrenal androgens. So you end up with massive overproduction of androgens.
Leading to virilization in females, for example. So the problem stems from cortisol deficiency. How do you treat it?
You give corticosteroids, like hydrocortisone in infants or prednisone in older children. But the goal here isn't just replacement. You give enough corticosteroid to suppress the excessive CRH and ACTH release from the hypothalamus and pituitary.
So you provide the missing negative feedback signal artificially.
Precisely. By suppressing ACTH, you reduce the stimulation of the adrenal cortex, which then decreases the overproduction of those androgens. It's using the drug to restore the normal feedback balance.
Clever. Okay, let's switch from replacement to diagnosis. How are corticosteroids used to diagnose Cushing's syndrome?
Cushing's syndrome is the state of having too much glucocorticoid hypercortisolism. It could be from a pituitary tumor making too much ACTH, that's called Cushing's disease, or an adrenal tumor making cortisol directly, or sometimes other tumors making ACTH.
But the most common cause isn't a tumor, is it?
No. By far the most common cause we see clinically is iatrogenic Cushing syndrome caused by long-term treatment with high doses of therapeutic glucocorticoids. The symptoms are the same.
So how do we use a steroid to diagnose endogenous Cushing's, the dexamethasone suppression test?
Right. We use dexamethasone, which is a very potent synthetic glucocorticoid with minimal mineralocorticoid effect. The principle is that giving an external glucocorticoid should suppress the body's own cortisol production via negative feedback on the HPA axis.
In a normal person, giving a low dose of dexamethasone overnight should make their morning cortisol level very low.
Correct. If their cortisol level is not suppressed, it suggests their HPA axis isn't responding normally to feedback that points towards Cushing's syndrome.
Okay, so that confirms Cushing's. Can it help pinpoint the cause?
Sometimes, using a higher dose test. If a high dose of dexamethasone does suppress cortisol, it often suggests the problem is a pituitary tumor, Cushing's disease, because the pituitary tumor cells might still retain some sensitivity to very strong negative feedback.
And if even the high dose fails to suppress?
That usually points towards either an adrenal tumor churning out cortisol autonomously or an ectopic source of ACTH, like a lung tumor, because these sources are completely independent of pituitary control and won't respond to dexamethasone feedback at all.
Okay, moving on to the biggest category of use, relief of inflammation and allergies.
This is where corticosteroids are indispensable. They provide symptomatic relief for a huge range of conditions: rheumatoid arthritis, inflammatory bowel disease like Crohn's or ulcerative colitis, asthma exacerbations, severe allergic reactions, inflammatory skin conditions. The list goes on.
Reducing that redness, swelling, heat, tenderness.
Exactly. They manage the symptoms effectively. You can even inject them directly into an inflamed joint, like for an osteoarthritis flare. But, and this is crucial, they don't cure the underlying disease in most chronic inflammatory conditions. They just suppress the inflammation.
And we have choices here too, based on potency and duration, right?
Yeah.
Like prednisone versus dexamethasone.
Yes. Prednisone is a workhorse, intermediate potency, intermediate duration. Dexamethasone is much more potent and longer acting. The choice depends on the severity of the inflammation, how quickly you need suppression, and how long you anticipate needing treatment.
And for things like asthma or allergic rhinitis, we can use them locally.
That's been a major advance. Using inhaled corticosteroids like fluticasone, budesonide, mometasone for asthma, or intranasal sprays for rhinitis delivers the drug right to the site of inflammation.
Which means less gets absorbed into the rest of the body.
Much less. This drastically reduces the risk of systemic side effects compared to taking oral steroids long-term. It allows effective local control with greater safety.
Okay, one more really important use: accelerating fetal lung maturation.
This is a fantastic application. Turns out, fetal cortisol is the natural signal that helps the lungs mature late in gestation, getting them ready to breathe air. It stimulates surfactant production.
Surfactant keeps the air sacs open.
Right. If a baby is likely to be born prematurely before the lungs are fully ready, there's a high risk of respiratory distress syndrome, RDS.
So it can mimic that natural signal.
Yes. If premature delivery seems likely, giving the mother intramuscular injections of betamethasone or dexamethasone, usually a couple of doses over 48 hours, crosses the placenta and speeds up the maturation process in the fetal lungs. It significantly reduces the risk and severity of RDS, a real lifesaver.
That's incredible. Okay, we've covered the what and why. Let's talk about the how, pharmacokinetics, and dosage. How do these drugs get absorbed and handled by the body?
Well, being lipid-soluble, they're generally well absorbed however you give them orally, injected into muscle or vein, put on the skin, inhaled.
The delivery route options are huge: 4 IM, intra-articular, topical, inhaled, intranasal.
Exactly. But regardless of the route, some systemic absorption is always possible.
Which brings back the HPA suppression risk, even with topicals or inhalers.
Yes, especially with high-potency topicals used over large areas or high doses of inhaled steroids long-term. Some drug gets into the bloodstream, and if enough gets in for long enough, it can potentially suppress the natural HPA axis function. It's something to always keep in mind.
Once they're in the bloodstream, how do they travel around?
They don't just float free. Over 90% of circulating glucocorticoids bind tightly to plasma proteins. There's a specific one called corticosteroid binding globulin, or CBG, also called transcortin, and they also bind to albumin.
Only the unbound drug is active.
Correct. It's the free fraction that can leave the bloodstream, enter cells, and bind to receptors. Then they're primarily broken down, metabolized by enzymes in the liver.
So liver function is important.
Very. If someone has significant liver disease, their ability to metabolize these drugs can be impaired. The drug can stick around longer, its half-life increases, and you might need to lower the dose to avoid toxicity. After metabolism, the inactive products are typically conjugated and then excreted by the kidneys and urine.
Let's revisit that prednisone and pregnancy point. Why is it preferred? It's a pro-drug strategy, right?
Exactly. It's quite elegant. Prednisone itself is inactive. The mother's liver converts it into the active form, prednisolone.
But the fetus can't do that conversion easily.
The fetal liver lacks the necessary enzymes or has very low levels, so the fetus is exposed primarily to the inactive prednisone. Plus, the placenta actually contains enzymes that can convert any active prednisolone that does cross back into inactive prednisone.
Like a double layer of protection for the fetus.
Precisely. It minimizes fetal exposure to the active glucocorticoid, reducing potential developmental risks while still treating the mother effectively.
Okay, let's talk dosing strategies. It's not just about how much, but how and when, right?
Absolutely. Several factors go into choosing the right dose and schedule. You need to consider the desired glucocorticoid effect versus unwanted mineralocorticoid effects. How long do you need the effect? What type of preparation are you using, short-acting, long-acting depot? And as we discussed for replacement, time of day can matter.
And the elephant in the room, HPA axis suppression. When does that become a major concern? What's the general threshold?
The general rule of thumb is that significant HPA axis suppression is likely if a patient receives large suppressive doses of glucocorticoids for more than 2 weeks. Shorter courses, even at high doses, are less likely to cause prolonged suppression.
So for chronic therapy lasting longer than 2 weeks, how do you minimize that suppression? You mentioned alternate day therapy.
Yes, alternate day administration can be a very useful strategy, particularly for intermediate-acting steroids like prednisone. The idea is to give a double dose every other morning.
How does that help?
On the off day, the steroid levels fall low enough to allow the patient's own HPA axis to wake up and function produce some CRH, ACTH, and cortisol. This helps prevent the complete shutdown and atrophy of the axis that can happen with daily high-dose therapy.
So it preserves some natural function. This is different from the split daily dose for Addison's replacement.
Very different. The 2/3 zone third replacement dosing is just trying to mimic the normal daily rhythm with physiological doses. Alternate day therapy is using supraphysiological high doses, but scheduling them to mitigate the inevitable HPA suppression during long-term anti-inflammatory or immunosuppressive treatment. It's an HPA sparing tactic.
Got it. Okay, that actually leads us into the challenging part, adverse effects and safety management. The power of these drugs comes with significant risks, especially long-term.
It absolutely does, and these adverse effects are often dose-dependent and duration-dependent. The source mentioned a study in RA patients showing the daily prednisone dose was the single biggest predictor of side effects. We have to take these very seriously.
Let's start with the most common one, osteoporosis, bone thinning.
Yes, glucocorticoid-induced osteoporosis is incredibly common and can be debilitating, and they attack bone from multiple angles.
Okay, break down those mechanisms for us. There are 3 main ones.
Right. First, they directly interfere with calcium absorption from the intestines. Less calcium available means less material to build bone.
Second,
Second, they directly inhibit the cells that build bone, the osteoblasts, so bone formation slows down.
and third,
Third, they decrease the body's production of sex hormones, estrogen, and testosterone, which normally play a protective role in maintaining bone density. So you lose that protective effect too.
a triple hit. So what's the management strategy for patients on long-term steroids?
Proactive prevention and treatment are key. All patients on long-term therapies should be ensuring adequate calcium and vitamin D intake through diet or supplements. And often, especially if they already have risk factors or are on high doses, they'll need prescription bone-sparing medications like bisphosphonates.
Okay, what about the visible signs, the Cushingoid appearance?
Yes, that classic Cushing-like syndrome develops with prolonged exposure to excess corticosteroids. It involves a characteristic redistribution of body fat, more fat deposition in the face, moon face, upper back buffalo hump, and abdomen, while limbs might get thinner due to muscle wasting. You also see skin changes like easy bruising, thinning skin, sometimes hirsutism, excess hair growth, and often a significant increase in appetite.
That increased appetite. Usually a problem leading to weight gain, but sometimes useful.
It can be. In patients with cancer or other wasting conditions, that appetite stimulation, along with sometimes a mild euphoric effect, can actually be beneficial for improving nutritional intake and quality of life. But it's still fundamentally a side effect of the drug.
What about metabolic and eye problems?
Because they promote gluconeogenesis, glucocorticoids raise blood sugar. This can worsen existing diabetes or even trigger steroid-induced diabetes, hyperglycemia. Diabetic patients need to monitor their glucose much more closely and often need adjustments to their diabetes medications.
And the eyes.
Long-term use is a major risk factor for developing cataracts. They can also increase intraocular pressure, potentially causing or worsening glaucoma. Regular eye exams are important for long-term users.
We mentioned skin changes with Cushing's, but what about topical use?
High-potency topical steroids, if used excessively or for too long, can cause significant local skin problems. Mark skin atrophy, thinning, ecchymosis, easy bruising, and characteristic purple striae, stretch marks.
And we need to remember the electrolyte effects, right? Related to that mineralocorticoid activity.
Yes. Even the more selective glucocorticoids can cause some sodium and water retention, potentially leading to or worsening hypertension. And they promote potassium loss, so there's a risk of hypokalemia, low potassium, not hyperkalemia.
Okay, arguably the most critical safety issue, stopping the medication. Abrupt discontinuation can be deadly.
This cannot be stressed enough. If a patient has been on suppressive doses for more than about 2 weeks, their own HPA axis is likely suppressed. Their adrenal glands have shrunk from lack of stimulation. If you suddenly stop the external steroid, they can't make their own cortisol.
Leading to acute adrenal crisis.
Acute adrenal insufficiency. It presents with severe low blood pressure, shock, nausea, vomiting, weakness. It can be rapidly fatal if not recognized and treated immediately with IV hydrocortisone.
So the rule is always taper.
Always, always taper slowly if the patient has been on steroids for more than 2 weeks, or even shorter periods at very high doses. The tapering schedule needs to be individualized, allowing the HPA axis time to recover its function. This can take weeks, months, sometimes even longer. Plus, tapering slowly also prevents a sudden flare-up of the underlying inflammatory disease the steroids were controlling.
A critical point. Okay, we've talked about giving steroids. What about blocking them? Let's cover the inhibitors of adrenocorticoid biosynthesis or function.
Right. These are drugs used mainly when the body is making too much adrenal hormone, like in Cushing's syndrome or hyperaldosteronism.
First up is ketoconazole. Isn't that an antifungal?
Primarily, yes. But at higher doses than used for fungal infections, ketoconazole is a potent inhibitor of several cytochrome P450 enzymes that are crucial steps in synthesizing all steroid hormones, adrenal and gonadal.
So it blocks cortisol production.
Yes, it significantly inhibits cortisol synthesis and testosterone synthesis too. That makes it a useful therapeutic option for lowering cortisol levels in patients with Cushing's syndrome, particularly when preparing them for surgery or if surgery isn't an option.
Okay, next is spironolactone. We mentioned it briefly as an aldosterone blocker.
Right. Spironolactone is primarily used as an antihypertensive and a diuretic, particularly in heart failure and liver cirrhosis. It works by competing with aldosterone for the mineralocorticoid receptor in the kidney.
So it blocks aldosterone's effects, less sodium water retention, more potassium retention.
Exactly. It's an aldosterone antagonist, but structurally it also resembles sex hormones.
Leading to anti-androgen effects.
Yes. It also blocks androgen receptors and inhibits testosterone synthesis to some extent. This anti-androgen activity is why it's used off-label to treat hirsutism in women.
But that same activity causes side effects in men.
Yes, the most common and bothersome side effect is a gynecomastia, breast enlargement in men. It can also cause menstrual irregularities in women, hyperkalemia, because it blocks potassium excretion, and sometimes skin rashes.
So useful but not perfectly targeted, which led to the development of eflaranon.
Exactly. Eplerenone was designed specifically to be a selective aldosterone antagonist. It binds strongly to the mineralocorticoid receptor, but has very little affinity for androgen or progesterone receptors.
Ah, so it blocks aldosterone's effects without the hormonal side effect.
Precisely. It effectively lowers blood pressure and is beneficial in heart failure, similar to spironolactone, but it avoids causing gynecomastia or menstrual problems.
Making it a preferred choice when those side effects are a concern, despite being more expensive usually.
Generally, yes. It offers a cleaner profile by targeting just the mineralocorticoid receptor. It's approved for hypertension and for improving survival in patients with heart failure after a heart attack.
Great. So we've covered the synthesis, the action, the drugs, the uses, the dangers, and the inhibitors. Let's try to synthesize this.
Well, we've seen there are these two major pathways, glucocorticoids like cortisol managing metabolism, stress, and inflammation, and mineralocorticoids like aldosterone managing salt and water. And the therapeutic use involves this really delicate balance.
Between just replacing what's missing.
Right, like in Addison's, where you're trying to mimic nature's physiological levels and rhythms.
And deliberately overriding the system.
Exactly. Using higher pharmacological doses to suppress inflammation or the immune system, which harnesses their power, but comes with that whole host of potential adverse effects and the critical need for careful management, especially regarding the HPA axis.
That HPA axis suppression and the need for tapering really stands out as maybe the single most important safety principle.
It absolutely is. And understanding that their action takes time because it involves changing gene expression is key to using them effectively and safely.
Okay, so as we wrap up, let's leave our listeners with a final thought, maybe connecting this deep dive back to everyday physiology. Given that glucocorticoid receptors are practically everywhere and they work by tweaking gene expression, what might the long recovery time of the HPA axis after a stress or steroid therapy tell us about chronic, low-level stress?
That's a fascinating question. If the system takes weeks or months to fully recover from a major suppression, what does constant lower-level activation due to chronic daily stressors do over years?
Could that persistent, subtle increase in the body's own catabolic and immunosuppressive signaling contribute to long-term susceptibility to inflammatory diseases or metabolic issues, even without ever taking a steroid pill? What are the deeper connections between our stress response system, our genes, and our long-term health?
It certainly suggests that managing physiological and psychological stress might have profound implications far beyond just feeling better day to day. It speaks to the very core of how our bodies maintain balance over time.
Something to definitely keep exploring. This has been incredibly thorough. Thanks for taking us through this masterclass.
My pleasure. It's a complex but crucial area of pharmacology.
Indeed. Until next time on The Deep Dive, keep digging deeper.